Thank you, Mr. Weeks. At this point, I'd like to highlight our first icon, who will be speaking this morning, Professor Anthony Kalloo. Anthony Kalloo is a professor of medicine at Johns Hopkins University and also director of the Division of Gastroenterology and Hepatology at Johns Hopkins Hospital. He has special interests in natural orifice surgery, therapeutic endoscopy, biliary and pancreatic diseases, and sphincter of Oddi dysfunction. Did I pronounce that correctly? Oddi dysfunction. This medical pioneer has multiple patents, multiple. I know some people in the crowd have some patents as well, so they'll appreciate that. Multiple patents including the use of botulinum toxin in the gastrointestinal tract. I apologize. It's a slip of the tongue, not a slip of the mind. Endoscopic cryotherapy and the winged biliary or pancreatic duct stent. One should also note his natural orifice transluminal endoscopic surgery. The acronym for that is NOTES. A technique that will enable abdominal surgery without the use of incisions. This was cited in 2014 as one of CNN's top 10 medical innovations. Give him a round of applause for that. Professor Kalloo is the founder and immediate past medical director of the Johns Hopkins Gastroenterology and Hepatology Resource Center, a 3,000-page multilingual web resource for patients and physicians. To date, he has authored over 190 scientific papers, review articles and books and chapters. Professor Kalloo is a past panel chair of the Gastroenterology and Urology Devices with the United States Food and Drug Administration and was also a recipient of the 2009 Distinguished Educator of the Year Award from the American Society for Gastrointestinal Endoscopy. And now I present Professor Anthony Kalloo, who will speak on his natural orifice surgery, the dawn of a new era.
Thank you very much for that very kind introduction. I prefer to be known as Tony Kalloo from Fatima. And I went to Woodbrook Presbyterian School on Priory Road. So, how many medical students or medical people are in the audience? So, medical students, residents? Residents, okay. So what I'd like to do, let me start off by also thanking the Board of Governors of NIHERST for this opportunity. I think it's fantastic. I was very excited to be here, and what I hope to present today is the work that I've had an interest in since 1988, which just began as an idea. And after leaving medical school, I did my training in the United States, and I joined the faculty at Johns Hopkins in 1988. I'm going to talk today about natural orifice surgery, or what's known as NOTES. And NOTES is an acronym for Natural Orifice Transluminal Endoscopic Surgery. And I'll explain that acronym as I go along. And I'd like you to stop me if you would like. Just stick your hand up if you have a question. Try to make it not too technical as possible. This is Johns Hopkins Hospital. It's been ranked the #1 hospital in the US for many, many years. And this is the city of Baltimore, which is right on the East Coast. And this is an actual image of the new Johns Hopkins Tower that was recently built at the cost of $1.3 billion US. So in thinking about this topic of natural orifice surgery, I'd like to start off by you thinking about the evolution of medicine. So think back to 100 years ago. 100 years ago, we had no antibiotics, no vaccination against childhood diseases, no treatments for high blood pressure, no effective treatments for heart disease, cancer, ulcers, or even hysteria. Most medications were herbal concoctions, and there were no synthetic medications. The doctors at that time had little to offer except their time and compassion. And this they offered with the assistance of knowledge available to them. And that was 100 years ago. And you say, wow, that's really bad, isn't it? But I would like you to think, what would they say about our medicine 100 years from now? Will they have a similar tone of disgust when they think about what we're doing? And they might, because they'll say 100 years ago, guess what? To do surgery, they actually made lacerations and they punctured the wall of the abdomen. And they made incisions across the abdominal wall to treat disease conditions. So maybe that might seem 100 incisions across the abdominal wall to treat disease conditions. So maybe that might seem 100 years from now quite grotesque. Endoscopy. I thought that maybe one way for us to... So endoscopy, I apologize, thank you for that, it's an excellent question. So the endoscopy of, how many of, well I wouldn't ask that because it's a personal question, but endoscopy is a technique where we take a flexible tube with a light and we look inside the gastrointestinal tract, either from above or below, which is called a colonoscopy. And this is a technique, it's non-invasive, it's a way to visualize the inside of your gastrointestinal tract, and you can see the lining of the intestines from both above and below. It's really important colonoscopy, which is endoscopy from below, and I hope you're familiar with colonoscopy, because it's a really effective form for screening for colon cancer. So thank you for that. I have to remember my audience. Yes, I appreciate that. So endoscopy, it's a really non-invasive way of examining the inside. And this actual video will explain what endoscopy is. Here you can see an endoscope which has been inserted, and this is a procedure that's routinely done, thousands of patients in Trinidad and everywhere around the world. But the endoscope is usually confined to the inside of the gastrointestinal tract. And that is, it was found that if you were to make a hole cause a laceration, the intestinal contents would leak into the cavities and cause sepsis, infection, and death. So my main work challenged that hypothesis, and my work focused along entering the peritoneum and the chest cavities through the gastrointestinal tract, where there are no external incisions, but rather using the natural orifices, like the mouth, the colon, the vagina, to gain access to these cavities and to treatment. So now you see this flexible endoscope coming out of the stomach, which is something that's never been done, and actually dissecting or removing the gallbladder. So this is a concept back in 1998 when we first started to do this, was considered heresy because to use the endoscope, which is that long flexible tool, to create a breach in the intestinal wall was considered a major complication. So why does this make sense? Why does natural orifice surgery make sense? Well, first of all, to avoid any incisions, as a physician, would be ideal. If you don't have an incision, you should have less pain, you will recover quicker, and then there's a cosmetic advantage of not having any scars. And we're sort of moving in that direction anyway. Surgery, many surgical techniques, such as removal of growths in the colon, which is what we do colonoscopy for, we now do with endoscopy. And I have a list here of diseases that were treated by surgery yesterday that we treat by endoscopy today. So if you look at this slide, on the left shows a typical open procedure for taking the gallbladder out. In the middle is what has evolved, which is laparoscopic procedure. So we don't make large incisions anymore. We use a technique of laparoscopy, which is making a small incision. And just that development of laparoscopy helped to improve patient outcomes. So instead of having an open surgery to remove your gallbladder, which would require 7 days to 10 days in the hospital, by doing it laparoscopically, you can go the same day. So we know that smaller incisions is better for you. So the hypothesis was that no incisions, or doing it through natural orifices, would be even a better step. And this has been the bulk of my work, which has been mainly done in the laboratory. I'm actually not a surgeon, but an endoscopist. And this has been the work I've done over the last 10 years. And there were many questions when we first started doing this procedure. Can an endoscope literally remove an organ? Can you do dissection like a surgeon? And can you do it safely? Were some of the questions that we had. This is a video, and again, for those of you who are medical students, this is actually one of the very first experiments we did back in 1998, where the endoscope is in the peritoneal cavity, and now we have, with this simple, long, flexible tube, we really have an excellent view of all the intra-abdominal organs, like the gallbladder and the liver.
And this is an experimental one, whereas the one you showed us before was an artist impression.
Correct. This was a completely artistic rendition. And we showed in this first experiment, which we published in 2004, that this was feasible with long-term survival, so that you can do it through the natural orifice and do it safely. And this first publication has been cited over 1,400 times since its publication in 2004. And this created a lot of anxiety because many of the surgeons who were traditionally trained to do open procedures and did not do flexible endoscopy were concerned because they asked themselves, well, can a non-surgeon or gastroenterologist actually do surgery? And is this a new era where surgery is, as we know it, is being replaced by more of an endoscopic technique? And so over the last 10 to 12 years, we've done many, many animal experiments to show that this is technically possible, that you can take a flexible endoscope and do surgical interventions. And this is just an example of one procedure, which is creating an anastomosis between the stomach and the intestine. This is a procedure that's done with bariatric surgery in order to help weight loss. And we showed that we were able to do this using a flexible endoscope. And not only did we, as a gastroenterologist, our specialty is digestive diseases, but we showed that we were able to do things other than digestive organs because there are other organs other than digestive organs in the peritoneal cavity. So one example is tubal ligation, whereas gastroenterologists showed that if you use an endoscope, this is all in the animal lab, by the way, this is not patient studies yet, that we could take an endoscope and insert it through the stomach and then do tubal ligations.
What animals?
These were pigs.
These were pigs.
Yes. And pigs have a very similar anatomy to us, despite the difference in the outward appearance. The internal anatomy is quite similar. So we were able to do many of these experiments, even spinal surgery we were able to do. We did experiments showing, for example, there are some surgeries for the fetus that are more beneficial before the baby is born. But traditionally, to do open surgery or to do it even with laparoscopy still has a lot of morbidity and mortality for the fetus. And so we did experiments to show this is a pregnant sheep model. We actually have the endoscope. This is the pregnant uterus. And here we can visualize the fetal heart. And we were able to show interventions in the fetus using natural orifice surgery in a way that is less aggressive and less invasive to the fetus than with the traditional ways. So there are many different surgeries that are listed here that have been done in the animal lab. And all of these were done in the animal lab. The first human nodes procedure was actually done by Drs. Rao and Reddy from India. And so this is no longer, are you looking at a pig, but this is an actual human. And this was a patient in India who had appendicitis, but had full thickness burns across the abdominal wall. So to make an incision or to even go laparoscopically was not feasible. So they decided this was a perfect candidate. They were doing lots of experiments like we were. Once we started doing it, they began doing experiments. So here you can see the appendix being dissected off of in the intestine using the flexible endoscope. And this video that you're looking at has been shown thousands of times all over the world because it meant for the first time that we could actually do an intervention, remove an organ without actually making an incision on the outside. and all of which using techniques with the endoscope, through the endoscope, to make this change. And this single video caused a lot of disruption because you publish pig experiments and people say, oh yeah, you could do it in a pig. But to do it in an actual human becomes a greater challenge. And can you do it safely, and can you do it without harm? So here you can see the appendix, well, if you noticed, was finally removed, and they're irrigating the abdominal cavity to prevent infection, just like they would in a regular surgery. But the difference is how the appendix is removed. And so, again, there are no incisions, so the only way you can remove the appendix is actually through the mouth. So you see the appendix being pulled out. So here you have an appendectomy without any surgical incision. So since this first human, actually over 3,000 patients have had nodes worldwide. It's not pure nodes. We're still in the phase where we're trying to develop technology, and I'll give you an example of a technology that we're working on that could help to develop nodes, because you're confined to devices that you have to use the endoscope through. So to stitch something, you stitch like this, as a surgeon stitches. But how do you stitch through a long endoscope? And now we have devices that can actually do that. We just published it, because there's such a large body of information on nodes, we published the first textbook in Orifice Surgery 2 years ago.
Who are your collaborators on that book?
These are all leaders in node surgery. Jacques Marasco is from Strasbourg, France. He's the head of URCAD, and Ricardo Zuron did most of his work in Brazil, but now he's in Germany. And these are two surgeons. And there's a large experience now with patients who have had even their thyroid removed. So just think about it. To have thyroid surgery, you have to have this disfiguring scar around your neck. And then they change from neck surgery to through the axilla. So they tunnel through the axilla, and you still have disfiguring changes. And now, because of nodes, we actually can go through the base of the tongue and tunnel into the thyroid and remove the thyroid this way without having any incisions. And what are the results? Well, actually, despite the concern about safety and all of that, so far there have been no mortality, there have been no patient deaths with node surgery, and the morbidity, meaning what are the side effects like infection and all of that, are the same to laparoscopic, comparable to laparoscopic surgery. So what are the future developments? This is one of many things that we're working on, but I'd like to show you this. This is a microgripper technology. And these are microgrippers shown on the left are like little hands. They're less than 1 millimeter in diameter, each one of them. And they can open and close like little hands. So this is a microgripper, and this is a capillary with a blood vessel, with a blood clot in the capillary, and the microgripper has been activated, and it uses changes like temperature or pH to activate the grippers, and then you can simply use magnets to move the microgripper from one area to the other. So this type of technology is feasible because if you have an endoscope and you can only use small devices through the endoscope because you're limited by the size of the endoscope, then this may have applications for surgery. Here you can see we have a catheter into the bile duct, and we have deployed the microgrippers, hundreds of them, into the bile duct, and then we will use the magnetic catheter. We activate them, so they have grabbed the tissue in the bile duct, and these microgrippers can be now retrieved with a magnetic catheter, and we can do analysis of the tissue to diagnose whether there is cancer or not using these tiny little microgrippers. So this is an example of one technology. So maybe these microgrippers deployed through the endoscope, if we deploy thousands of them, can do organ removal, can put drug treatments through that question.
So, like science fiction, how far are you from that technology?
So we have made progress with this technology in terms of deploying them and looking at different characteristics that will cause them to be activated in terms of opening and gripping tissue and closing. So what you've seen, what I just showed you was an actual experiment, yes?
So when you go into the body, though, maybe I'm not understanding, you're still going through cavities, you're still not cutting through tissue. Once you get in, you're still having to cut through, or is it all through microducts and micro orifices and?
So with natural orifice surgery, we take an endoscope, which is a long tube, and we go in, but we still make an incision into the stomach. It's not an outside incision, but the lining of the stomach there is no pain, and there's no scar tissue that's formed. So it's less invasive. But now that we have this endoscope in here, now we can deploy these microgrippers and maybe have the microgrippers specially made to target the gallbladder, and then they remove the gallbladder. Yes?
Maybe it's out of the domain of this talk, but I couldn't really follow why a change in pH or a change in temperature would activate a mechanical object.
So there is a whole technology behind this. And there are people probably here who might know more about this than I do, because this was done by a PhD researcher at Hopkins. So he has the original technology. We simply adapted this technology to endoscopy.
Well, let me answer that.
Yes,
because what you find is that if you take almost any material, as you vary the temperature or the pH or the external pressure, you reach certain points at which things suddenly happen, so-called phase transitions. And the simplest one, which we all know, because we see it now in refrigerators, is that if you make water cold enough, it becomes solid.
Yes.
And so what it turns out is that if you design the material appropriately, then you will find out that there is an appropriate sensitivity. And often it's controlled by temperature, and temperature is the subject.
Yeah, I can understand temperature.
But pH, essentially any variable of pressure. So there are materials which under pressure become superconductors, and under normal pressure are not. And so it goes. And if you take liquid helium, for example, and normally that flows without any friction as liquid helium. But if you put it under about 30 atmospheres pressure, it becomes solid helium. And so now you have to say, well, we look for ingenious engineers to design the materials. And Dr. Kalloo will say, well, it would be nice if, and then you have to think of the basic properties.
The thing about it is that temperature affects all phases. pH is really a solution phenomenon.
No, it's a similar phenomenon, because the pH, I mean, now you get a little technical, and I'm happy to talk technically as Dr. Kalloo is. But the point is the control of a pH is really what's called a chemical potential. And so if I increase it, I put in more of some iron or less of another. And it turns out that this is essentially just the same as temperature, because all you're doing when you say temperature is increasing the amount of movement there. That's
I agree, but I'm still
So
not
at the point where the sophistication is that they can do it even by cell type. So we can target, say, cells of the gallbladder versus cells of the liver. So it's, I mean, these nuances are not my area, but this is what we use to help adapt the technologies.
We have one question back here.
Yes.
Thank you very much, Professor Kalloo. That's really awesome stuff. I'm more on the business side, and I keep thinking about cost and implication. You mentioned a number of about 3,000 surgeries of this type so far. I'm sensing this is still in research phase, not yet commercially applicable.
Correct.
Do we know anything about the cost implication of this for doing these types of surgeries?
So I think the cost implications are tremendous. So if you think about an operating room, which is probably one of the most costly things. The reason an operating room exists is to have a sterile environment in which bacteria doesn't enter our bodies when the surgeon makes an incision. So everything is scrubbed and everything is perfectly sterile so that when the incision is made, there is no infection that goes into the body. With natural orifice surgery, your environment now becomes different. It's not the external environment is critical, it's actually the environment inside the gastrointestinal tract. So it is conceivable that you don't have to have a sterile environment to do surgery. In fact, that once you are able to have a sterilized endoscope and sterilized accessories go in, and then you can have a major impact on cost. Because again, the cost of an operating room is significant. That's one point. The other point is that doing natural orifice surgery also makes surgery portable. So, for example, if there was a motor vehicle accident and someone is bleeding from a liver laceration, instead of taking that time to take the patient to the hospital, into the operating room, if you're able to do surgery right there at the bedside, you go right away to the patient's mouth, you sterilize the gastrointestinal tract, you make your incision, you identify the bleeding, and then you stop it right there at the point of interaction, or in military warfare. So it could be a very significant cost benefit to doing this procedure.
The potential is extreme. I'm accepting that 100%. I'm just curious as to when will this technology be a good full commercial launch that is applicable? Do we have any idea?
So you're right. 2020 is when I sort of predicted this.
2020.
Yeah.
I get it.
I had a video, but I guess it got deleted along the way.
Yeah. So you had another, Dr. Kalloo, you had another question over there.
Yes.
2020 was what catalyst?
Yes.
How effective will it be in, let's say, a surgery that these people who have blockage they have? Microgrippers.
So, I mean, that could be one possibility, that you deploy these microgrippers into the coronary vessels to remove plaque and all of that, because, I mean, simply because of the size. So I think that's an excellent point. Yes.
I'm trying to imagine the size of the endoscope is that. Just goes on, does it house all these microgrippers and other components that take part in the surgery? This one endoscope?
I'm sorry, if the...
This instrument?
Yes, the endoscope, yes.
And does it house all these other instruments? The microgrippers?
Yeah. So this instrument, and again, I apologize, I didn't know for sure what my audience was going to be, has working channels. So you could put catheters through, you can put different devices through. So imagine it like a long telescope, but through this telescope you can put devices through. And that's how, for example, we can do a biopsy or we can remove things. So you could put a catheter and you can deploy the microgrippers through a catheter through the endoscope.
But the other point you were making is crucial here, namely that one can make things very, very small and very reliable these days. And so that's, again, ties in with the question that I was asked about the control of things at a small scale. And so it's really quite amazing what one can do. And so sort of the answer was yes. If you looked at some of the pictures, you actually saw it borrowing and then putting things on, then putting something else on and putting that on. And so that's all very, very small. And so the question is, well, how small is it? And once you get well below millimeters.
It's a micro stage, not in that.
No, that's right.
The difference is
It's a micro, it's not that, exactly.
So to end, I thought you would get a little kick out of, many of you may have seen the TV show ER. And I don't know if you did hear it.
Yes, most definitely. Can it be done with a laparoscope? We'll try. So we have a conventional procedure. I use my abdominal muscles to help me breathe.
It's surgical surgery.
My state, it's at least a basic procedure. No, this is it.
Yeah, we don't do that here. It's experimental.
There's a doctor called Professor Anthony doing clinical trials at Northwest. He's had over 50 cases.
You're cutting a hole in its stomach. You leave setting yourself up for peritonitis.
It's a 2mm incision that's occluded by a balloon and transport. When you're done, you close immediately with G-Prox. They've had great success.
You want to call this guy in?
Well, this has to be state of the art.
See if he's willing to help and available today. Long shot.
So this is a patient that we couldn't operate on in the conventional way. And Dr. Santiago, who does not look like this, is actually a nurse researcher international student. We've got a lot of cases, but definitely does not look like this guy.
Oh, right, yeah, I've heard all about it. So, this thing's really gonna happen? Well, let's go. I can't. I've got a couple of cases we have to check in on.
Well, the residents do.
Go ahead. I'll be in and out, you guys. This thing's massage? Yeah. Lucian, heard about the notes and happy? Pretty cool. Yeah, it is. Pretty cool. Excuse me, officer. Stop this right off. Never cheers.
Tom.
Attention, that's your leader. Still at it? Yeah, just in time for the big finish.
Index is out. How cool is that?
So yeah, Hopkins. Okay, thank you for your attention.
I didn't want to interrupt before, but I'd like to talk a little bit about the anastomosis because I have a painful, almost first-hand experience with it. Somebody who was like a sister to me had ovarian cancer. The tumor was in what is called a cul-de-sac between the vagina and the colon. The surgery was at Sloan Kettering, 1999. And the surgery took 9 hours, predominantly because of the anastomosis, which had to be created because, as I said, the tumor was burrowing into the colon. The person who operated on her was, at the time, Sloan Kettering's star surgeon, a woman called Elizabeth Poyner. So when I saw her afterwards, she told me, and I can see her now, she was excellent. She said, you know, I could have done it, you know. I could have done it. But, meaning she could have done the anastomosis. She had done the bulk of the surgery. But I wanted to call in this guy because he's the expert. So she took time to call in somebody to do the anastomosis. So they also have to shunt the bowel to an external bag. That is one aspect that I wanted to ask about. But here's the other. When that anastomosis broke down, some 4 or 5 years later, more like 4, and the patient suffered and suffered and suffered. She never told them. When eventually she told Poyner, they had to go back in and fix it. And Poyner was asking, why didn't you tell me? But here's the thing. I understand this. I am still seeing the look in Poyner's eyes of a top surgeon when she did not want to do the anastomosis. I'm also thinking of the fact that the expert, that this surgery took 9 hours with an expert. And I'm also thinking about the fact that it broke down. So in doing it as a note, doing an anastomosis, short term, yes. I'm wondering what happens. I think we also need to test the surgical procedures, that not just the clipping and removing, but if you do something as complicated as an anastomosis, I think rigor demands that you test the robustness of it compared to the ordinary way of doing it. Not everything that you do by note will require anastomosis. And by the same token, you also will need note or no note to create that external path. So there will have to be an incision for some things. But looking at this, and I applaud you, this is wonderful. And I tell you why too. I was a kidney donor, and I had a big incision that took me a while to get over. Now they're doing kidney removals laparoscopically at any rate. And soon maybe, I don't know if they could pull a whole kidney through a natural orifice, but maybe if a baby comes out, they could.
They have.
They have, right? So, speaking personally, with my kidney donation, I appreciate that anastomosis, though I'm still seeing the fear in that woman's eyes, a top surgeon, not fear, but at least the hesitancy about tackling something like an anastomosis.
Well, I mean, anastomosis, those are excellent points. And that's why notes is still experimental, and that's why the question of 2020 is the answer. And that's because there's a lot of scientific rigor that's necessary before you can do widespread notes. But clearly, early on we showed if we could not do an anastomosis through an endoscope, then notes could not be performed. And we've had now several thousand patients who have notes done under experimental conditions. But to show that it is feasible and we can do anastomosis. But there's still a lot of scientific rigor that needs to be done.
But how long does it take to break down? This is what I want
So
to check.
there's no single answer for everyone. A child that has an anastomosis versus somebody who is 75, versus somebody who is 30 and in good health, versus somebody who is 55 and not in good health, will all have different outcomes. So there's no one single answer in medicine. And in terms of notes for, there have been patients who have had donated kidney donors like yourself, who have had no incisions because they were able to remove the donor kidney transvaginally. They were all women, and their recovery was amazing, faster than the surgeons have said than anyone else. So there is no single answer in terms of outcomes for one patient versus the other, and nothing in life is 100%, especially medicine. But clearly, this whole idea is really to show you how you can take a concept and with time and with, perseverance and patience, that you can have a concept developed where it actually is something that's doable. And these details...
I'm going to intervene here too and say, look, one of the great things of knowing who the leading doctors are, which I always say, and it's very important when we're talking about science and education generally, is that they know what they don't know. And that's one of the crucial things. And you heard Dr. Kalloo saying, well, we don't know the answers. And further, it's going to vary. And you have to say that every patient is in some sense an experiment. Okay, I've had heart surgery, some things didn't go according to plan. Okay, so that's inevitable. But then you have to say, well, what was the consequences otherwise? And I had a sister, the one who was born in Tobago, who died prematurely. And my first vision of her when I was 5 years old was seeing her in hospital. Okay, and so
I just want to say for the residents and the training in medicine and those that are here is that you can make differences if you have concepts that are novel, if you have an understanding of the physiology, and if you have perseverance.
Let me just say one thing before you go. I see the wonderful advantage of notes. It's not a question of whether notes, because for one thing, you don't need an anastomosis with every notes surgery. The point I'm making, and in the case of anastomosis, in her case, it was a localized breakdown. It had nothing to do with general health. It was a localized breakdown because of the nature of an anastomosis. And the surgical, so it was a surgical defect after X amount of years. So it really had nothing to do with the general health of the person, which was good outside of this ovarian cancer. So I think we still need to test when there is complicated surgery.
Yes.
The longevity.
All right, thank you, Professor Kalloo. Thank you, Mr. Fisher, Professor Stolt, for your